for the MDoloris medical systems. MDoloris is a company that we have responsibility for in probably 25 states, maybe. And I have invested a significant amount of money, and we have demo equipment in stock. I have sent one demo unit to Omaha, Nebraska for Darren Trull. Otherwise, we're awaiting the opportunity to send out more to everyone. So we're excited about this product. In the last couple days, I've done some Google searching and some reading of studies, and it just points out that the savings that a hospital can get per patient with this device are significant, and the cost could be as little as $28. So to get potential of $500 to $5,000 in savings per patient for a cost of $28 seems to me very well worth it. So we're going to spend the next 60 minutes or so with Charlie Forbes. So I'm going to put myself on mute and turn it over to Charlie. Thank you, Charlie.
You're welcome. Thank you for having me, and thank you for partnering. We're really excited to launch this product. So I am a Vice President of Sales for North America. I'm a critical care nurse by training, and much of my career has been in the operating room. I will be your point of contact today for clinical help and support, as well as sales help and support with Kevin and his team. So really, I'm looking for you guys to help drive where I best support you, how I can best provide value for you. Today, the objective is really to get you familiar with what the technology is capable of doing, and walk you through data, show you how the disposables are applied and used, and then we'll finish it up with some of the talk tracks and tools that will be available for you. So this is the monitor. This is a high-frequency variable index monitor. It comes in two pieces, one of which is the standalone monitor that attaches to an IV pole. We are working on integration of this monitor into a module. We have two companies working with us. One is Masimo, the other is Mindray. We just launched about 2 weeks ago the Masimo product, the Masimo module, into the European market. So that product is moving along nicely, and we anticipate having that here in the next 12 months. So that will help us as well. It also comes with a disposable, and we'll walk through what that disposable is. So what is the high frequency variable index? What does that do? It's a heart rate variability monitor. So we are 510(k) cleared in the US to measure heart rate variability. So when the heart beats, it produces an electrical signal, the ECG. The top of each wave is the R wave. When you breathe in, your heartbeat speeds up very slightly. Breathe out, your heart rate slows very subtly. That's called heart rate variability. So it's not the speed. We don't measure the speed from the R to R beat or how slow it's going. We measure that variability based on inspiration and expiration. It's a continuous reading. It's a physiological parameter, just like heart rate and blood pressure.
Please re-enter your access code followed by the pound or hash sign.
If you guys haven't muted, go ahead and mute again. This monitor turns that heart rate variability.
To enable audio controls, please enter your audio PIN followed by the pound or hash sign. If you do not have a PIN, just press pound or hash.
Hey, Charlie, you might have a mute all button you can press.
Yeah, let me see here. I can make this. Oh, good. Thank you. All right. So this monitor turns that heart rate variability into numeric values 0 and 100. Okay. The higher the number, the more heart rate variability. The lower the number, the less heart rate variability. So what does heart rate variability mean, right? What is the intended use for this monitor? It's actually a monitor that looks at comfort pain and nociception, right? So let me walk you through what that is. We are currently working on that FDA indication for use, but let me walk you through how the rest of the world is using this technology, so you can understand how we will be selling this technology as well, and how to discuss pain and nociception within the clinical environment. So there's a system in the body called the autonomic nervous system. The autonomic nervous system controls those things in the body that you can't physically control with your brain. So for example, digestion is controlled by the autonomic nervous system. Fight or flight is part of the autonomic nervous system. You don't get the choice to whether or not you're startled or not. Temper is controlled by the autonomic nervous system. There are two halves of that autonomic nervous system. One half is the parasympathetic system. One half is the sympathetic nervous system. So the sympathetic nervous system speeds up the body, right? The sympathetic nervous system is responsible for increasing heart rate variability, increasing temperature. It's also where pain and nociception live. So the definition of pain, let's talk about pain and nociception for a minute. The definition of pain is a psychological response and a physiologic response that is uncomfortable, stressful, painful to the patient, right? Well, under anesthesia, you block the patient's psychological response to discomfort or pain, to that neurologic stress. Because of that, we call pain under anesthesia something different. We call that nociception, okay? So nociception is pain, it's just the physiologic pain without the psychological pain. So if your patients are awake and talking to you, they have pain, and they may have pain. But if they're under anesthesia and they have a sedative on board, so they no longer have that psychological response, they have nociception, which is the physiologic response to surgical stimuli in the operating room, okay? Pain and nociception live in the sympathetic nervous system, okay? That's going to be important to know. The opposite of the sympathetic nervous system, then the other half of that is the parasympathetic system. That is what this monitor measures. It measures the parasympathetic activity of the body. The parasympathetic system measures the calm of the body, right? It's the relaxation, it's the slowing body, okay? That's what we measure. So if you think about this monitor being a comfort monitor, right? Measuring the parasympathetic system, that's what you need to understand to utilize this technology, right? It measures the parasympathetic system or the comfort of that patient, okay? One of the things your providers may ask you is, or respond to you for, is the sympathetic nervous system is where pain and nociception live. Well, the theory behind this monitor is that if the autonomic nervous system is whole, and we know half of the autonomic nervous system, can we equilibrate the other half? And the answer is yes. So we're always measuring the parasympathetic system and the comfort of that body. And we do that through heart rate variability. So when you look at the parasympathetic system, there are three things that make up the parasympathetic system. This is important, not for conversation with your doc, but it's important for you to understand because it tells you when the technology works and when the technology is not going to work, okay? So the three components of the parasympathetic system are the sinus atrial node. That is the pacemaker cell of the heart. That is what keeps the heart beating. So you have to have a functional beating heart in order to use this technology. So let's be devil's advocate. If you have a patient who is on a pacemaker firing at more than 9 beats per minute, this technology doesn't work, right? Because a pacemaker fires according to a clock, and you lose that heart rate variability, okay? You have to have a functional pacemaker cell or SA node. So if your patient is on pump and the heart is not beating, does this technology work? No, it does not work when your patient does not have a functional SA node. All right, so the first step of the parasympathetic system is having a functional SA node or a functional beating heart. The second requirement to have an intact parasympathetic system is to have a stretch on the baroreceptors. So the baroreceptors are in the lungs, and they respond when you inhale or exhale, and there is stretch on those baroreceptors. Okay, that's required to have an intact parasympathetic system. Now, the monitor doesn't care whether that stretch on the baroreceptors is spontaneous breath or whether or not that patient is mechanically ventilated, right? Because almost all of our patients in the operating room are mechanically ventilated. That's great. But if they're not breathing or if they're not mechanically ventilated, this technology does not work. So, for example, when a patient goes on pump in the operating room and they're on the heart and lung bypass machine, they're not receiving mechanical ventilation through their lungs. So again, during cardiopulmonary bypass, if they are on the heart and lung machine, this technology would not work. If they are breathing on their own or mechanically ventilated, you are good. And you have to have a functional hypothalamus. And there are very, very few conditions, and I've never seen any sort of bleed in the hypothalamus, but that would be the only indication. If they had a hypothalamic bleed, we may see this technology, definitely interpret with caution with this technology. So there are really three components to anesthesia, right? There is the sedatives or the hypnotics that we use, that's at the top of the triangle. There's the areflexic drugs we use, which are our muscle relaxants, right, and our paralytics. And then there are pain medications to prevent nociception under anesthesia. Current practice today shows us that areflexia is measured in every anesthetic case it's used in with a train of 4 or some sort of nerve stimulator. The consciousness of your patient or the response to the hypnotic drugs that are given are measured with a consciousness monitor in anesthesia. The only portion of the anesthetic today that is not monitored is the analgesic component or the nociception component until today. That's what this monitor can come in and how they're using it overseas to measure the impact of the analgesics and put a numeric value to the impact of those analgesics and allow providers to titrate. So this technology is currently cleared for heart rate variability. That's what is cleared in the United States. We have additional indications for use that we are working through the FDA process to achieve. We anticipate having several of those. We anticipate having additional, what that provides is additional reasons for providers to use the technology. Okay, so right now today it is 510(k) cleared for heart rate variability. The first indication for use we are working on through the FDA process is the indication for use of pain and nociception. Okay, so anytime you're going to discuss pain and nociception with your client, with your customers, you just, in order to stay within the FDA guidelines, you just let them know that we are working on this indication for use and that is how they are using it overseas. You can definitely have all scientific conversations around published data, so we're going to dive in quickly and talk about the published data in just a minute. This is the disposable piece that goes along with the with the monitor. It's a sensor that goes across the chest. The rectangular piece goes below the clavicle on the upper right-hand side of the chest. And if you're a clinician, you know about the V leads, right? The V leads are on the lower side of the left chest and kind of go underneath the chest. But anywhere the sensor can get an ECG signal, it works. So it's very, very forgiving. You can have the sensor on the back. You can have the sensor on the right side. You can have the sensors on the left side. As long as it captures an ECG signal, you are good to use the sensor, okay? The sensors, the two pieces of the sensors are connected with a cable, so sometimes it does get in the surgical field. So a couple of options, one of which is to just have your providers put a piece of tape, pull that cable out of the surgical field. That works in 99% of the cases. Or you can adjust sensor placement and move that sensor. The sensors come in 100 per pack. Within that 100 per pack, there are 10 sub-packs. The sensors are good for 2 years after the customers receive them. And they're good for 6 months after a pack has been opened. And they're good for 24 hours on your patient. This is the 24 hours on the patient. This is not a problem in the operating room, in the ICU. So what we see in the intensive care unit, if they're going to be using it, is they'll either date and time it and change it every 24 hours, or they will just change it every AM with their AM care, their bath care. So overseas and in Europe, and what we're working through the FDA for indication for use for pain and nociception, remember, this is a parasympathetic comfort monitor. So the higher the numbers, the more comfortable the patient is. The lower the numbers, the less comfortable or painful the patient is, okay? The data says that there is a sweet spot, that 50 to 70 is really that range where your patients will wake up comfortably in the PACU, and they will wake up, or they will wake up with discomfort that is tolerable for them, okay? The other thing this technology does is it predicts hemodynamic responsiveness, okay? So for example, if your number continues to fall below 50, you have an increased probability that your patient will have a hemodynamic response, meaning an increase in heart rate and blood pressure greater than 20% off the patient's baseline. So a lot of times you'll hear discussion in the operating room where they want to keep their patients very, very stable, right? For example, they've had a myocardial infarction, so they don't want elevated blood pressure, or they're very concerned about blood loss, and so they don't want an elevated blood pressure. This monitor will tell your providers, if it falls below 50, they have an increased probability of having some sort of hemodynamic response associated with that. And we will go over the data that proves that. So right now, what you say is this is a tool to help titrate your analgesics. 50 to 70 is really that sweet spot that allows the providers to not give too much analgesic or not enough analgesic, okay? So this is what the monitor looks like once it's on and functional. And I'm going to start at the bottom of the screen. At the bottom of the screen, you see your ECG. That tells you that, yes, your sensor placement is adequate, okay? If you put your sensors on and you're not seeing a good ECG, go to the right, hit the reset ECG button, and that will, your sensor will take a little different look at the electrical activity. If not, if you cannot capture a good ECG, then you need to adjust placement slightly, okay? Let's move to the top. On the upper right-hand side, you will see two numbers, one in yellow and one in orange. These are the numbers that your providers will use to titrate their analgesic. So the yellow number is the instantaneous number. That's the acute number for the amount of comfort in the body, right? That's the sweet spot where we say it's 50 to 70. As that number starts to decrease, right, there is less parasympathetic activity, less comfort, okay? As their numbers tend to increase, there is more parasympathetic activity and more comfort. So in this case, the yellow numbers are the instantaneous number. They are always looking at 60 seconds worth of data, okay? That 60 seconds worth of data is an acute number. It tells you where the patient's comfort is going. Above it, in orange, you will see the mean number. The mean number is always looking at 4 minutes worth of data, and that is the number that is being used to titrate analgesics, okay? So the instantaneous number tells you the direction that that patient is going. The mean number will show you, is the number that is less reactive and will show you where that patient is going, okay? To the left of that, you will see the trend screen. The yellow is the instantaneous, and you can see how it's more responsive, and the mean is in the orange. Below that, you will see the respiratory pattern screen, okay? What you need to know about the respiratory pattern screen is that is a graphical response or graphical trending to the physiologic response of the parasympathetic system. So the takeaway is the bigger and more the graphic is in that screen, the more parasympathetic activity you have. The smaller the waveform is within the respiratory pattern window, the less parasympathetic activity you have, and the smaller that number. It is really not essential to, providers really do not use the respiratory pattern on every case. You'll have a few providers that want additional reassurance on the numbers, but 99% of your providers, a very high percentage of your providers, titrate their analgesics according to the number in the upper right-hand screen, right? So what are the benefits? The benefits are the ability to titrate your opioids, right, both under and overdosing, and this is tricky. This is really, really tricky. So all the providers have books that tell them what an acceptable dose of analgesics should be. But we have a lot of patient conditions we're going to discuss that really make that process tricky. And I'm just going to give you one now so you can kind of start thinking through that. And that's patients who are on either recreationally using opioids or narcotics, or those patients who are on prescribed analgesic medications for chronic pain, even acute pain. The Cleveland Clinic said in a study that 1/3 of all of their patients were coming in with an altered response to the analgesics that they give because of either recreational use or because of prescribed analgesics. So this is a really great place to start in your conversations with your physicians, right? I hear other physicians talk about opioid use in our culture, making anesthesia tricky, right, for the provider. What's your experience, right? And they'll go in and they'll talk about not being sure of how much to give. This technology can help give them the assurance that they need to give more or that they can feel confident giving less, okay? And we'll walk through those examples in another slide. Another benefit is the ability to diagnose the cause of the hemodynamic event, right? So an example of this, when you put a tourniquet on a patient in the operating room, they automatically have hypertension and tachycardia. So providers will look at that hypertension and tachycardia and not be sure. Is that because of the tourniquet, or is that because my patient is having pain and nociception? This technology will help differentiate that diagnosis for you, right? So if a patient is hypertensive and tachycardic and their high frequency variable index number is between 50 and 70, then you can, that provider can be assured that that hemodynamic response is not because of pain and nociception, right? And they know it's because of the tourniquet, and they actually use different drugs for that particular, to treat that particular cause. It's also, this technology is also predictive of post-operative pain. So the ability to assure that your patients wake up comfortably in the PACU. So we're going to start talking about some of the data. And this was an article that came out last month, June 2017, in A&A, which is, if not the premier anesthesia magazine, one of the premier anesthesia magazines in the U.S. And this technology, and this article looked at, does this technology have an impact on the amount of fentanyl drug that is given in the operating room when we're looking at laminectomies and discectomies? So they looked at spinal cases. And what this paper did was it proved to be very, and I need to send you this paper, so I will do that. But what this study proved and looked at was that there's a very strong statistical significance in those patients who have their analgesic titrated to an ANI or to a high frequency variable index versus non-ANI, right? So ANI is what they call the technology in Europe, okay? So you will see anti-nociception index. That's what they call it in Europe. In the US, we are calling it high frequency variable index monitor. But what this study showed was that those patients who had their analgesic titrated to the technology saw a significant decrease in pain post-operatively and had significant difference in comfort post-operatively. So the study methods, there were 50 patients, so that's pretty well powered. It was randomized and controlled. It was randomized, so that also provides or improves the quality of the research. And there was a control group. One group received fentanyl according to the technology, and one group received fentanyl according to their standard practice. And the technology guided group, so the providers who titrated their analgesic to the technology, their patients showed that they were more comfortable in the PACU. So on a scale of 1 to 10, patients came back to the postoperative care unit 1.3 points more comfortable than those without the use of the technology. But these next 2 points I want to talk about are significant. The study showed that there was a 64% less fentanyl administered for the group that had their analgesic titrated. That's a significant number. So there was also a decrease, so there was a 64% reduction in the amount of fentanyl used in the PACU. So they received less analgesics in the PACU. And there was an 82% reduction in the postoperative nausea and vomiting in the PACU. Also statistically significant. Postoperative nausea and vomiting is troublesome for our providers and for our patients. It significantly lowers postoperative patient satisfaction scores, and it's quite expensive. And Kevin has created a tool that we will show here at the end. So the conclusion of the study shows that if you guide your analgesic use or you guide your fentanyl administration, that it will result in less postoperative pain, nausea, and shivering in comparison to standard practice. If there's one study you need to have on you, that this is it, and I will make sure that I have sent that to Kevin for you. Some additional studies, also important. This first one looks at ANI during surgery. It's a total of 9 patients under general anesthesia, and what they did was they observed the technology to see if it was responsive to surgical stimulation. So if we're going to cut the patient for incision, if there is going to be pain provided to that patient, you would expect the technology to do what? You would expect the technology to decrease in its number. And that's what the study showed. So if you look at this, T1 looked at after induction prior to incision. So in T1, when the patient is getting ready to be operated on, you should anticipate that the high frequency variable index numbers are high, right? But the white line here on the screen shows incision. Once there's incision, you would expect a monitor like this to decrease, and it does. You can see that monitor decrease, okay? Now, this is on T3, they're showing just prior to extubation, and we discussed if that technology is below 50 prior to extubation, you can anticipate your patients being uncomfortable in the PACU. If the technology is in that sweet spot, that 50 to 70 range, prior to extubation, you can anticipate your patients waking up comfortably in the PACU. And that's exactly what this study shows. In this study, you can see that before extubation, they are below 50, okay? And below 50 prior to extubation tells us they wake up painful in the PACU, and that's exactly what happened. Now, in the PACU, which is T4, you can see that they gave an analgesic. When you give an analgesic to this patient, or to your patients, you would expect their comfort number to increase, and that's exactly what we saw. So this graphic example is just a very standard example of what you will see every single day in the operating room. Those numbers after intubation will start out high. Surgery will start, and you will see that they fall into that kind of the surgical range. Below 50 is an indicator that they will wake up painful. Above 50, 50 to 70 is an indicator that they will wake up comfortably. So this is a study that looked at 15 patients, and they looked at propofol and remifentanil. And really what the purpose of the study for is to differentiate. Does this technology really look at nociception, or is it looking at something else that could have an influence on it? So as part of this study, what they did was they looked at blood pressure, they looked at heart rate, they looked at the BIS monitor. So the BIS monitor is a consciousness monitor. It measures the sedative. And they wanted to make sure in this study that the consciousness monitor is always different than the analgesic monitor. And that's what this study shows, is that we are not looking at the consciousness of the patient. So there was a nociception. So when there was no stimuli, okay, in no stim 1, you'll see on the graph, you can see blood pressure's fine, heart rate's fine, and you can see the patient is very comfortable. They're above 70, and you would anticipate that. They've just gotten induced, they have a general anesthetic on board, and there's no surgical stimulation, right? So let's go to surgical stimulation. With surgical stimulation, you would expect your high frequency variable index monitor to decrease, and it does nicely. You can see the blue circles, okay? You can see that through this entire event, there is no change with the consciousness monitor or the wakefulness of the patient. So the patient is never awake during any of this. Yet you can see that clearly, when it comes to nociception, there is some sort of event. Now let's look at heart rate and blood pressure. Your providers will tell you every day you will hear in the operating room that I titrate my analgesic based on heart rate and blood pressure. And while everybody, you'll find your providers will agree that it's not the greatest tool, they'll also tell you it's the only thing we have, right? They don't have other indicators of the analgesic need for the patient. And we are the first to market with that indication. So this is a nice example of how you can show that there is a nociception event, right? There is a nociception event happening, yet blood pressure and heart rate don't change, right? Blood pressure and heart rate are actually a very late indicator. So you see that blood pressure eventually does go up, but it is after the nociception event. So what this technology allows you to do is to intervene with an analgesic prior to the hemodynamic instability, right? And you can argue that heart rate is not an indicator of nociception at all. And you can also, a lot of patients receive drugs in the operating room that alter their heart rate and blood pressure. So even if the patient did want to respond hemodynamically, they can't. And the perfect example of that are beta blockers. So beta blockers are given to slow the heart rate, prevent the heart from working quite so hard. Very common drug given in the operating room. While beta blockers slow the heart rate, the speed of the heart, they do not have an impact on the variability from beat to beat. So if the patient's getting a beta blocker and your anesthesia provider is used to using heart rate as an indication for when to use an analgesic, they've really lost their primary tool that they use in the operating room. This technology can help, right? This technology can let you know the exact physiologic response that patient is having to the stimulation within the operating room. So this is a nice study. It looks at 50 patients, so it is significantly more powered. But what this study looked at was with remifentanil and propofol, and they looked at what is the specificity and sensitivity of the monitor. So when it comes to nociception, does it really look at, so what measures nociception? Is it the BIS monitor? Is it the ANI monitor? And they performed ROC curves to look at that. And the takeaway is that this monitor has a sensitivity of 88% and a specificity of 83%, which are very, very powerful indicators that this technology does what it's supposed to do, which is look at the nociception. This technology, when we talk about predicting postoperative pain or postoperative comfort in the PACU, this is the study that really looks at that, and it's really well powered and well done study. There are 200 patients that they look at. They use remifentanil and propofol, and they did a couple of different things. So on the graph on the left here, you will see what the technology numbers were that between 20 and 100, and then you will look at what the pain scales are when they come to PACU. Okay, so the higher the number, the high frequency variable index number, the more comfortable the patient is. Okay, the higher the pain assessment number, the more comfortable the patient is, right? And we find a very, very nice linear response to and correlation between the high frequency variable index monitor and patient's comfort on the PACU. So for the patient that was very, very painful, right? The 10 or the 20 down here, they woke up very, very painful in the PACU. Those patients who were above 70 also woke up very, very comfortable in the PACU. But really what we're shooting for is that 50 to 70 range. And those patients in the 50 to 70 range were waking up comfortably or with tolerable discomfort in the PACU. But this is interesting. If you look at the graph on the right, what this study also showed was that those patients who have low high frequency variable index monitors or ANI numbers, who have low ANI numbers prior to extubation, came to the PACU painful, and it was also took significant amounts of time to achieve comfort in those patients. So there is a growing trend with the thought process that if they wake up uncomfortably in the PACU, it is very, very difficult to get them. You'll hear the PACU staff talk about catching them up, right? Trying to get them caught up and to get them comfortable again. And this study replicated that same process, right? So it looked at, again, predicting postoperative comfort or pain, and that patients who were in that sweet spot, that 50 to 70 range, did wake up with in the PACU comfortably or with tolerable discomfort. So those are kind of the primary science that goes in behind this technology. So who's a candidate for the use of this technology? Elderly patients can be very, very tricky. And there's also their metabolism alone makes them tricky for analgesic administration in the operating room. This technology will take the guesswork out of that and allow them to titrate their analgesics. Children can be very tricky, right? Too much, too little. And this technology works with children down to the age of 2. Okay, so they have to be 2 or above. This is a beautiful technology in those patients who are non-communicating, not a very high percentage of our population. Bariatric patients, this is the patient we see every day in the operating room. And bariatric patients are challenging when it comes to their analgesic, because when you first deliver, typically when an analgesic is first delivered, there is an absorption of that analgesic into the adipose tissue. So the analgesic doesn't necessarily go where it needs to go to have an effect in the body, okay? After a couple of doses, that adipose, the receptor sites in the adipose tissue become absorbed, and then you see the analgesic given really going towards what it's supposed to do, which is provide comfort. So they also tend to retain the analgesics, so particularly the opioids. So if there's a lot of opioids given in the operating room, it increases their risk for having complications in the postoperative care unit. And then additionally with this patient population is they have a lot of risk postoperatively. And all of the drugs we give our patient for analgesic are weight-based calculated drugs. And that becomes challenging for the providers because the analgesic, the weight-based calculations don't always work appropriately for the bariatric patient. And so instead of using weight-based calculations, you can titrate the analgesic to have the effect needed in these patients. This is a great technology for end-of-life care. Probably won't be a significant target of us, but in case it comes up in conversation. And then lastly, I think probably the biggest target for us are those patients who have altered drug tolerances because of either recreation or pharmacologically prescribed analgesics. It's an incredibly high number of patients that we see. So real quick on competition, there is none. Nothing is cleared in the US right now competing against us. However, there are a few technologies overseas that we anticipate will someday work their way to the United States. So for right now, if you do hear about a competitive technology, bring it back to Kevin, bring it back to me, and we'll have some conversations. But we do not anticipate you seeing anything competition related. So what are the tools? There's a couple of tools that you can use, and I'll walk you through the website on how to do it. The first is the brochure that we talked about, and I will show you our website, and we will walk through how to get to our website. All right, so our website is MDoloris.com. When you put that website in, it will pull up a map, okay? If you are talking about high frequency variable index, you can go to the US side. If your patients, if your providers are, if you're discussing the non-FDA cleared use, intended for use with your providers, or you're talking about the science associated with the ANI or pain, then you go to the rest of the world, okay? In the rest of the world, you go up to the menu box, you click on English, and you hit technology. This is where you find the link for all of our brochures. So, hold on. You're going to want to go to the adult pediatric monitor. And at the bottom of this, you will see the link for our tool, okay? So if you want to send a bibliography of everything published on this, there's over 90 pieces of published abstracts, poster presentations, good quality evidence. This is where you would get that tool. If you want to send the brochure, right-click on the download. Download this. And it will pull up the brochure. You can send the link to the customer here so they can access the brochure. It's loading, so one second as it loads here. All right, we'll open up the brochure. This is what the brochure shows you. Okay, it goes into a quick overview. So the way I use the brochure and the way the brochure was very helpful for me when I first got started is it's a really beautiful summary of the technology. So not only did I use it with my customers, but I also reviewed it prior to going in and having these conversations with my customers, because it's kind of a refresher on all the things we just discussed. So the first section of the brochure is, what is it and how does it work, right? Then you page down to what you're actually looking at and what the technology is capable of doing for your patient. It talks about the studies we just reviewed. So it can predict hemodynamic instability. It's helpful in diagnosing the cause of hemodynamic responses. And then it discusses who, right? What kind of patients might this technology be useful for? It goes into some of the science that we've talked about, right? So instead of trying to memorize all the data, use your brochure to kind of walk you through the most, and allow you to walk your customers through the most important data. It talks about the clinical, some of the clinical studies that we reviewed during the lecture. And that's what the brochure is able to provide for you. And then you have me as a resource. So I will be available to run cases, help with evals, right? And you can connect with Kevin, who can put you in contact with me. Or we should probably just make sure that you all have my contact information, and then copy Kevin in on the communication. So that's the technology. What are your, I know I gave you a lot, but really it breaks down to a couple of very simple things. One of which is, it's a tool to help you titrate your analgesic, that we're working on the 510K process for that indication for use. You will have to convince no one that analgesics are bad for your patients, right? That is the #1 trend in the operating room today, is how do we give less analgesics, right? Everybody values that, but there's a lot of angst with how to do that appropriately, because providers don't want to give too little, right? They're afraid of giving too little and giving too much. So this is a tool that'll take that concern away from them. Kevin, I'm gonna go ahead and pull up your tool here.
Charlie, while you're pulling that up, I have a quick question. What is the ideal number range for a BIS monitor? If we're 50 to 70, are they, do we correlate with them? And I know they're measuring something completely different, but what are they looking at?
Yeah, so they look at 40 to 60, so their range is slightly different. And you will almost always see a difference between the BIS and the ANI. Exactly why, the reason you said is because they measure two different things. So the BIS will measure how awake or how asleep that patient is, and the high frequency variable index monitor then will measure will measure how painful the patient is. So there's usually not a correlation between them because they do measure very, very different things. However, I will say, if you have a provider who uses a consciousness monitor of any kind, and that's a great question to ask. If you currently use a consciousness monitor, the theory to use a consciousness monitor is very, very similar to the theory to use the high frequency variable index monitor. And that theory is, does objective data help you make better clinical decisions in the operating room for your patient? And if they're using a consciousness monitor, they have said yes to that. They have said, yes, objective data helps me make better decisions in the operating room, okay? The same is true for the high frequency variable index monitor, right? Is there a chance that objective data can help provide information that will allow you to give precision analgesics in the operating room? So if they're using a consciousness monitor already, for me, that's a lower line fruit because they're already used to looking at objective data.
Hey, Kevin, can you hear me?
Yes.
Yeah.
This is Jerry, and Charlie, you showed in that one graph where the BIS monitor was showing that the patient was unconscious all the way through the procedure, whereas your monitor was showing a drop and the patient was in pain. So there is no correlation. You had that slide earlier.
That's exactly right. Very good. And by the way, you just got a gold star. One of my favorites because that was a really good catch. Nicely done.
So if the MDoloris is monitoring for, the nociception or what is the BIS, and the BIS is for basically how deep or asleep they are, is the BIS helping them titrate medicine at all? What's the benefit to using the BIS? I mean, is that the benefit they're titrating still? Okay.
Yes, let me answer that with an example. So you have a patient whose blood pressure goes up and heart rate goes up right away. What's the cause of that? It could be that the patient's waking up, right? Because patients who wake up in the operating room, if there's not enough sedation on board, they could wake up and it could cause a hemodynamic response. So they'll look at their BIS monitor. Is the patient waking up? And they'll say, no, the patient's not waking up. The cause of that hypertension and hemodynamic instability is not because they're waking up. Well, then they're left with, well, is it pain or is it an acute hemodynamic response? And those are treated differently. If it's pain, they're going to give an analgesic. If it's some sort of physiologic response happening in the operating room, that might be treated with a primary antihypertension, right? So they may give a blood pressure drug, right? So now they have the ability to go, okay, it's not a consciousness problem because I've got my consciousness monitor. And now they can look at this technology and say, help them make that decision. Is this acute hemodynamic instability related to nociception? Yes or no? And then if say their analgesic, their high frequency variability index is in that sweet spot, that 50 to 70 spot, then they can look at the primary cause being of that hypertension being physiologic, and instead of treating it with sedation or instead of treating it with an analgesic, they treat it with a primary antihypertensive. And so it's a decision-making tool for them, more information for their decision-making matrix.
I understand what you're saying there, but if they have one of these two monitors, they can rule out basically one of those two causes, and then they could, if they have a BIS monitor, they know it's not consciousness that's causing it, then they know it's nociception, or they know it's, is there a need to have both of these is basically what I'm asking, because it seems like to me, if you have one, you can rule out the other. You know what I mean?
No. Remember, there's the third component. There is there is the physiologic hypertension and tachycardia too. So there are three things that can cause this hemodynamic response. It could be sedation, it could be analgesic, or it could be just a primary cause, right? So for example, if the patient's having a heart attack, okay, and they have their blood pressure goes up, right? Because the heart wants to try and, push against, disperse that blood more. That would be a primary antihypertensive need, right? So there are physiologic things within the OR. There's a third component to that will cause hemodynamic instability as well. So if there were only two, then yeah, you could use one and assume the other, but there's not. There's a third, and they do it all the time. They give analgesics every day, sometimes every case, where they will give a primary antihypertensive, right? So for example, if the patient's got a history of hypertension, and they come in and they're on blood pressure pills, right? Well, did they take their blood pressure pill that morning? Did they not take their blood pressure pill that morning? There are a lot of things that can go into that decision making. So the need for both monitors are there. They are separate. They give different information, and both sets of data are important for decision making for the provider.
That makes sense. Thank you.
You're welcome.
I have a question for you. What does this? Oh, sorry. This is Brad in Iowa. Does this fit into any kind of NICU neurologic ICU call points at all when you've got people that are obviously heavily sedated?
Yeah.
I'm wondering how they are.
Yeah, great question. So we're going to take our guidance from Kevin on this, but I'm going to give you my thoughts. So when you look at selling, so this technology works very, very well in the intensive care unit, whether that's a neurologic intensive care or cardiac intensive care, any place they're giving analgesic drips and the patient has lost their consciousness, which is pretty much every single mechanically ventilated patient in an intensive care, this technology can provide value. Couple of things to keep in mind. One of which is when the patient is awake, your best measurement is the patient's verbal response, right? So they'll say, can you use it in the awake patient? Well, you can, but there's things that interfere with it in the awake patient. It is always best. But if they are in an intensive care, sedated, mechanically ventilation, and on an analgesic, this is a perfect technology for that. Now, I will tell you, in my experience, ICUs are a beautiful place for hardware, but they don't burn the same amount of disposables as the operating room. So if I had two equal targets, an operating room or an ICU, I would go after the operating room every day because they're gonna significantly use more disposables because the ICU patient is gonna have one disposable for 24 hours. Now, so that's how I would start. If everything was the same, I would always go after the OR target. Now, if somebody you will find that a lot of intensivists in the ICU are anesthesia trained. And so they may hear about this technology and want to use it. If there is a desire to want to use it in the ICU and you think it's a lower lying fruit, absolutely target it. But for example, I wouldn't start off I would start off with spending my valuable time and resources and effort in the operating room and then branch off to so once you have a good OR, well then maybe you're spending time anywhere, spending time there, then you look at the ICU. But I would definitely start in the operating room unless there's a reason to make that ICU target a good one.
Do you want to discuss
Okay,
the document that we have in front of us?
One more time. Oh, Kevin, you want to talk about this?
Well, I'll talk about it, sure, a little bit, but I kind of want you to go over it also. But basically, it takes, the essence of this document is to point out that there are numerous companies, like this company called Premier Analysis, that has come up with the actual cost when a patient experiences vomiting in the PACU or whatever. And with the powerful studies that say we can reduce PONV by 82% and reduce drug administration and pain scores, and then reduce the length of stay of a patient, it can have, you know, anywhere from $500, $600 to, you know, multiple $1,000s of impact, and that's all available to them for a $28 sensor. I mean, we will loan this monitor to them on consignment with the cost of a sensor being $28, with the only requirement that they use it on a daily basis. And that's probably, that proposal would not be available to an ICU, Brad, because once again, they're not going to use as many sensors potentially. But we might give them the same plan, but maybe give them a cost of $38 per sensor. So we do have some flexibility. But initially, this unit costs $9,000 or $9,500 is the list price. We pay like $6,000 for it. So you know, to be able to get, you know, 10 units in a hospital, I think the fastest way is going to be this consignment program where we charge them only $28. So looking at the cost, the potential savings per patient, the $28, you know, I hate the term, but it should be a no-brainer.
So Kevin's exactly right. What we're doing with this tool is to try and find cost justification, to put a cost justification model in your hands. And if you look at the first section of this tool, these are the results from the Upton study. The one study I said you have to have on you at all times while discussing this technology. And the Upton study, these are the results. So what do those results mean financially, right? And actually went out and did some research on what is the cost, the average cost of some of these complications. And so really it's working to get you a cost justification tool. Postoperative nausea and vomiting is expensive. But even as expensive as it is, patient satisfaction is going to be a really important piece to hospitals receiving reimbursement from the government. And so you can imagine what happens to patient satisfaction when there's postoperative nausea and vomiting. So you'll see more on this tool, but just know it's coming your way.
Believe me, there is no anesthesia provider that enjoys having their patient have an experience of nausea and vomiting in the PACU. It's almost like, you know, I'll say a scarlet letter, so to speak, that somehow he did his anesthesia improperly for that patient. You know, everybody in the PACU, all the nurses know who did the anesthesia, and they know that the patient's, you know, sick from it. So, you know, it's something they don't want. So it could be a great question to say, you know, if there was a tool that could decrease nausea and vomiting in the PACU by 82%, would you consider it? You know, so how you couch your questions could be a key thing. The other thing I was thinking, and I would like your comment, Charlie, it might be appropriate to make calls on definitely the director of the operating room and also chief nursing officer. I believe these are, if you could go to the director of surgery prior to going to anesthesia and ask these questions and almost ask permission to be able to show this to anesthesia, it might be a great pathway to success, because then you could go to anesthesia and say, hey, this is, you know, your director of surgery is interested in this, or the director of nursing is interested in this. and they're going to appreciate any tool. I will. What are your comments about that, Charlie?
Yeah, so I think we're going to grow up a little bit together. I would absolutely have those conversations, and I think we'll have to continue to bring our feedback back to this team so we can develop the best, best practice for that. For me, I think you're spot on with that call point. I think the decision to use or not to use will always be in anesthesia. So you still have to do the evaluation, gain the support of the providers. But as we're trying to compete, trying to get dollars through capital, trying to get fee-for-use agreements signed, those conversations with those call points, those high-level call points are going to be critical, that they understand what they're getting for their very minimal investment. So I totally agree with that, Kevin.
Can you hear me?
I can.
Yes.
These numbers would indicate to me that the current protocol in the OR is actually underusing analgesics. Is that correct? I mean, that's what we would assume from this, right?
No. So I will send you the Upton article. So this is tricky and complex. So what we learned from the Upton article was that in the two groups, right, the group that had guided analgesics and non-guided analgesics, the amount of drugs given in the operating room was actually pretty similar. The significant difference was how and when they gave their analgesics. So for example, in the non-titrated group, the providers gave random doses of analgesic, right? In the technology-guided group, they gave precision analgesics based on when that patient needed it. And what was interesting was the analgesic, the technology-guided group had a lot more drug up front and less drug in the back. So now we're starting the conversation with maybe it's not so much the amount of drug you give, but when you're giving it. And if you can give it with precision in the operating room, that's not proven yet, but it's a very quick article to read. And actually, if you read the abstract, which is half of the first page, you'll have what you need to talk about that subject. But the amount of drug in the two groups was not statistically significantly different, which was a bit of a surprise for us. But the outcomes were very, very different. So, is there a benefit to giving your analgesics when you get analgesics? I think we're going to be answering to that question.
I just wanted Tim here made a comment that I think is worth repeating. Basically, what we're really needing to do is send that patient to the PACU in that 50 to 70 range, which is that tolerable comfort range, because if they're over sedated, or I shouldn't say that, if they're over analgesed or over narcotized, in other words, they're up in the 70 or 80, they're going to have more opportunity for post-operative nausea and vomiting because they may have too much drug on board. And then other complications also occur, such as everything from collapsed airway, unresponsiveness, constipation, all those kind of things. So if they go into the PACU with a low number, like below 50, then they're going to be also a chance for nausea and vomiting, but they're also going to be in pain, and then they're not going to give a good satisfaction score. So once again, if they're over-sedated, that's a problem. It can cause challenges with airways and nausea and vomiting. If they're over-sedated, and if they're under-sedated, they end up, I shouldn't say under-narcotized or pain analgesia, they'll end up having other problems. So that's why we need to have them be precise and be in that 50 to 70 range.
Spot on.
Hey, this is Jerry again. What is the potential for these patients even leaving PACU and going to the ICU, of just leaving the sensors attached and having a monitor up in ICU and just connect them there, because like we said, they're going to be on some heavy drugs, and I would think that would be a key point where they want to watch this.
Absolutely, that would be fantastic. You're absolutely thinking along. So once you get your operating room up and running, then they've got the disposal on anyways. You know, it can just follow them right up to the monitor that's sitting waiting for them for use in the ICU. Absolutely.
The key thing though, Jerry, is not that many people go to the ICU that are in surgery. You know, the key thing is this. She mentioned all the different people that this will work on, but it's really for any long surgery. I think in general, when I've talked to anesthesia providers, they'll act like they know where they are with their patient. Well, they probably do know where they are from a